introduction so she can start bringing up her slides, and also give me a chance to bring up the bio here. Gerda is now a retired pediatrician and neonatologist who subsequently worked as a staff neonatologist in Amsterdam at Leiden University Medical Center and at the Hospital for Sick Children in Toronto. Dr. Meijler has served as a staff neonatologist also at the, I don't know if I'm going to pronounce this right, but the Asala Women's Children's Center, also in the Netherlands, until she retired in October of 2022, but she still holds a research appointment. Her clinical research and teaching and PhD thesis have all focused on fetal and neonatal neurology, and particularly neuroimaging. And she's the co-author of many papers and textbooks on these subjects. So I think I could go on and on about what a wonderful person, instructor, neonatologist, parent, grandparent, all these other wonderful titles that she has, but I'm going to let her kick off her talk.
Well, thank you so much, Alexa, for this kind introduction. And yes, my maternal parental tasks are very extensive nowadays, but I won't talk about that today. I just want to mention the lighthouses that you see here. This is a lighthouse in the southern part of the Netherlands, and Alexa also showed a lighthouse which is in eastern US of A. And my talk will be on neuroimaging and neurodevelopment in moderate and late preterm infants. Human brain development is a very protracted process that starts in the early embryonic period and continues until adulthood. The first trimester of pregnancy is characterized by massive cell proliferation and migration, and this is followed by the establishment of connectivity, which includes axonal in- and outgrowth, differentiation of the neurons, including the dendrites, and synaptogenesis, which includes even beyond adolescence. It also includes pruning and apoptosis, and pruning means the programmed elimination of abundant synapses, and apoptosis is programmed cell death. The process of gyration and sulsation starts in the early fetal period and is already finished a few weeks after birth, while myelination starts relatively late, proceeds very slowly until birth, then accelerates during infancy and continues into adulthood. Today, I will focus on the late fetal period and on moderate and late preterm infants. And you will see many of my grandchildren, but also children of my nieces. And so it's a lot of family that you are going to see today. I will start with an introduction. Then I will talk about brain growth and development. And this includes gyration and sulsation, myelination, and neuronal dendritic differentiation. Then I will spend some time on neurodevelopment in this vulnerable group. And the last part of my talk will be dedicated to the BIMP study, and BIMP is short for brain imaging in moderate and late preterm infants. And of course, I will wrap up with some conclusions and a recommendation. Annually, about 15 million infants are born prematurely worldwide. And more than 80% of these infants are born between gestational ages of 32 and 37 weeks and are thus moderate and late preterm infants. And we all know that prematurity is a risk factor for brain injury and developmental problems and impairments. Although the group of moderate and late preterm infants is so much larger than that of very preterm infants, the focus of research and medical progress has traditionally been on the very preterm population, and these are infants born below a gestational age of 32 weeks. However, moderate and late preterm infants are also at risk for suboptimal and abnormal neurodevelopment, for behavior and even psychiatric problems, and for impairments. And these problems are often less severe than in very preterm infants, and they also occur less frequently. But as the group is so large, their burden, their socioeconomic burden is larger than that of the very preterm population. And many studies and probably thousands of papers have been dedicated to the subjects of brain development and brain injury in very preterm infants. But we don't know so much about these subjects, and especially not about injury in moderate and late preterm infants. And this is a figure from a very interesting paper published by a large group of people in Nature in 2022. And they have included about 125,000 MRI scans performed in about 100,000 subjects, with ages varying between 115 days post-conceptional and 100 years. And these subjects were included in about 100 primary studies. And so if we look here at these lines here, the gray dotted line represents the mean cortical thickness. And we can see a massive increase throughout gestation with where the maximum is reached almost around birth. The other lines, this one represents the white matter volume. This is the subcortical volume. The pinkish one is the gray matter volume. The dotted pink one is the total cerebral volume. And the dotted green line is the total surface area. And we can see that all these are increasing steadily throughout gestation with an acceleration during the last weeks before birth. And this rapid brain growth is also expressed on this graph from a paper by Kinney, where the gestational age is expressed on the x-axis versus the percentage of the full-term brain weight on the y-axis. And if we look here at the situation at 24 weeks gestation, the brain weight is still far less than 30% of the full-term brain weight. And between 26 and 40 weeks, the brain weight increases more than twofold, while the volume increases more than threefold. And between 30 and 40 weeks, the cortical volume increases fourfold. But not only during the early preterm period, also during the later preterm period, the growth of the brain is impressive. Because if we look here at the situation at 34 weeks gestation, the brain weight is still less than 70% of the full-term brain weight. And between 35 and 40 weeks, the volume of the myelinated white matter increases fivefold. And the cerebellar growth is even more impressive than that of the infratentorial structures. Again, here the post-conceptional age in weeks on the x-axis versus the cerebellar volume on the y-axis. At 27 weeks, the volume of the cerebellum is still less than 5 milliliters, and at 40 weeks, it's more than 25 milliliters. So it needs to increase more than fivefold in this period. At 34 weeks, the volume of the cerebellum is still less than 15 milliliters, and again, needing to increase to 25 milliliters. And these are graphs from a paper by a Croatian group that is very well known from its beautiful studies on human brain development. And what we see here is again on the x-axis, the age in post-conceptional weeks, versus the surface areas of the frontal lobe, temporal lobe, occipital lobe, and parietal lobe. And let's skip these structures for the time being. And what we see again is a steady increase of these surface areas throughout the fetal period, with an acceleration between 35 and 40 weeks. And this is especially so for the frontal lobe. And this is, of course, related to the process of gyration and sulsation. And many of you probably know these illustrations. This one is from the book by Barkovich and Rebaud, and shows the fast progress of gyration and sulsation, which starts around 14 weeks gestation with the formation of the Sylvian sulcus, but the interhemispheric fissure is even develops before that time. And it's a highly orchestrated process that occurs in a fixed sequence and pattern. It progresses very rapidly, and all primary sulci develop between 14 and 27 weeks gestation, and the whole process is completed around term. And this is a timetable from a recent paper by a Filipinian group, and they have looked at gyration from an ultrasound perspective in babies admitted to their wards. And these babies had post-conceptional ages between 24 and 42 weeks. And they've looked at about 400 ultrasound scans that were done in these patients. And they described the changes of the cerebral surface. Between 24 and 26 weeks, they still see a very smooth brain surface. And then the primary gyri appear as early as 26 weeks and are present in a majority at 27 weeks post-conceptional age. The secondary gyration starts as early as 28 weeks and is present in the majority of the infants between 29 and 30 weeks, while tertiary gyration appears already at 32 weeks and is present in the majority of infants at 36 weeks post-conceptional age. And they describe the typical cobblestone appearance, I call it more a walnut appearance of the brain, as early as 36 weeks post-conceptional age, and this is present in all neonates at term. And of course, we can also look at the process of gyration when we perform neuroimaging in our preterm population. And these are MRI scans, the left ones performed in a baby scanned at a post-conceptional age of 34 weeks, and on the right, for comparison, a baby who was scanned shortly after birth and was born full term. The top scans are T1-weighted parasagittal scans, of course, and the bottom ones are T2-weighted scans at supraventricular level. And if we first look at the situation here in the preterm baby, we see quite a typical phenomenon, which is that the occipital area is already beautifully folded, and the same is more or less true for the parietal region, while the frontal area is still rather smooth and is showing at the most some undulation. And we must realize that there are regional differences in gyral development within one brain. The fastest development takes place in the occipital areas, and this is followed by the parietal region, and the frontal area is the last to develop. And here on the T2-weighted scan, we can see that all primary sulci are there. There are also many secondary and even some tertiary sulci present at this age. And we also see some left-right difference, which is normal. And then in the full-term situation, we see that the occipital area is, of course, nicely folded, which is also true for the parietal and the frontal region. And on the transverse scan, we can see all these beautiful deep sulci. We see the secondary sulci, and we see tertiary sulci present. And of course, one of the major advantages of cranial ultrasonography is that we can perform serial images from birth until term equivalent age or even beyond that age. And this enables us to follow brain growth and follow brain maturation and to follow lesions in our preterm infants. And these are high quality mid-sagittal scans performed in a baby born at the gestational age of 32 weeks, scanned shortly after birth. And for comparison, a full-term baby also scanned shortly after birth. And what we recognize here, for those of you who are not familiar with ultrasound images, of course, this is the corpus callosum over here. And then below the corpus callosum, we see the cavum septum pellucidum, the cavum vergae, here the very echogenic fornix, the thalamus over here, the mesencephalon, here the vermis of the cerebellum, still small and smooth at that age, the fourth ventricle, the pons, and here above and parallel to the corpus callosum, we see the cingulate sulcus, which is not completed yet at that age. Well, in the full-term baby, we of course recognize the same structures, and we see this beautiful cingulate sulcus that we can follow over its complete length. We also see secondary sulci, tertiary sulci, and we see an enormous difference between these two scans in about 8 weeks' time. Also, we recognize here the parietal occipital sulcus, and this is the calcarine sulcus. And look at the cerebellum, that is much larger, the vermis, than in the preterm infant. Then myelination. As I said before, this predominantly takes place after birth, although some regions, mainly in the brainstem and cerebellum, already myelinate from mid-gestation. And we can see myelin present in the brainstem, cerebellum, and a bit in the thalami from a post-conceptional age of 28 weeks onwards on fetal and preterm MRI scans. Myelination progresses very little and very slowly between 28 and 36 weeks post-conceptional age. And around 36 weeks, we can see myelin appearing in the posterior limb of the internal capsule. And probably all of you know that at least a third of this structure should be myelinated around term age. Between 36 and 42 weeks, we can see myelin appearing in the corona radiata and in the remainder of the cortical spinal tracts. And these are again MR images, and these are T1 weighted images, transverse images at mid-ventricular level. This one in a baby of 33 weeks gestation, scanned shortly after birth, and this was a full-term baby, again scanned shortly after birth. And you can see that this was a traumatic birth, which was also the reason for the early MRI scan, with here subdural hemorrhages, quite some molding of the skull, but the brain looks normal, fortunately. And what we see here is a tiny bit of myelin present in the thalami. We also see that the posterior limb of the internal capsule and also the anterior limb, that the signal intensity is lower than that of the surrounding deep gray matter. And so this white matter structure, which is still unmyelinated at that age, has a lower signal intensity than the surrounding deep gray matter. In the full-term situation, there's more myelin now in the thalami, and we see that very nicely a third of the posterior limb of the internal capsule is now myelinated, as it should be. And we also see that the low signal intensity of the posterior limb of the internal capsule that we saw in the preterm infant, that is not present anymore, because we see some sort of, here we still see that it's a bit lower than the surrounding deep gray matter, but on the left side it has the same signal intensity, as is also true for the anterior limb, and this is due to beginning myelination and pre-myelination. And here we see some myelin appearing around the central sulci. Then T1 weighted parasagittal scans. This one you've seen before with the far advanced folding of the occipital area. And here just a tiny bit of myelin in the thalamus and some myelin in the dentate nucleus of the cerebellum. And this baby was born at 29 weeks gestational age. And she couldn't be scanned around term equivalent age because of the corona pandemic. So we needed to postpone her scan. And so she was scanned 8 weeks after term age. And this is a beautiful scan, as you can see. We now see that the posterior limb of the internal capsule is completely myelinated. We also see beginning myelination here in the central white matter, appearing as a somewhat higher signal intensity and continuing even into the subcortical white matter. What we also see is beginning myelination in the rest of the white matter, especially here in the occipital area. And this causes a loss of contrast between the cortex and the immature white matter, because here the white matter is still completely amyelinated, thus has a low signal intensity, while here the white matter is obtaining some signal intensity, is getting whiter, more bright, and thus it loses the contrast with the cortex. And also look here at the cerebellum, where we see beautiful myelination in the dentate nucleus, also spreading into the peripheral white matter of the cerebellum. And also look at this beautiful foliation of the cerebellum, which enables an enormous increase of the cerebellar surface. And then here, two drawings on the left side of an immature neuron versus the mature neuron on the right side. And the neuron has a cell body with its nucleus and one long extension, that is the axon, that sends information to other neurons, and numerous short extensions that are called the dendrites that receive information from other neurons. The mature neuron has a larger cell body, has a longer and thicker axon that is now covered with myelin, as you can see, but it's not completely covered. Some parts are skipped, and these are called the nodes of Ranvier. And impulse conduction over the axon jumps from one node to the other, and this is called saltatory conduction and enables an enormous increase in velocity of conduction over the axon. The dendrites now look way more complex, and they look more or less like the branches of a tree, and this is called arborization of the dendrites. One mature neuron can make contacts with tens of thousands of other neurons, and we have billions of neurons in our nervous system. And I cannot calculate this, but maybe you can. calculate how many connections we have in our nervous system. And so this neuronal dendritic differentiation is also shown by this figure from a paper by Andyman. The dotted line represents a transition between the immature white matter and the cortex. A few weeks after mid-gestation, the cortex is still a very simple structure, mainly consisting of densely packed neurons that are arranged along vertical columns. And the major transition is taking place around 30 weeks post-conceptional age, when we can already distinguish these 6 different layers of the cortex, each consisting of differentiated neurons. While a few weeks after term, we can of course still distinguish these 6 layers, but we also see that the neurons are now much less densely packed, and this is due to the increased size of the neurons and the ongoing arborization of the dendrites. And so far I've talked about brain development in the late preterm period or the late fetal period, and I would now like to spend some attention to neurodevelopment in moderate and late preterm infants. And these infants are also at risk for suboptimal development in all domains, not only in the motor domain, but also cognitive and language domains. They are at risk of cerebral palsy, although their risk is lower than that of the very preterm population, but it's higher than of the full-term population. And they are at risk for behavior problems and autism. Their language performance is less than in full-term born children, and they face more school problems, and these include grade retention and the need for special education. Their problems are not only present during childhood, but they may persist into adulthood, as their mean job performance and mean income is lower than that of full-term born subjects. And because this group is so large, their healthcare consumption is similar to that of very preterm infants until 10 years of age. And here we see a graph from a Scottish paper where they show the proportion of children needing special school education versus the gestational age in weeks. And so here in children born between 33 and 37 weeks gestation, the need for special education is 1.5 times higher than in children born at term. And this need for special education increases again after 41 weeks. And all these problems that moderate and late preterm infants are facing, in combination with the lack of knowledge on their brain development and brain injury, prompted us to start with the BIMP study. And this BIMP study was conducted by Vivian Boswinkel, at that time a PhD student, and here she is holding her last included BIMP baby, and now she is training to become a pediatrician. And we started the BIMP study with a systematic review on brain injury and altered brain development in moderate and late preterm infants. We couldn't include that many papers because, first of all, there are not so many papers on this subject. Secondly, not all the papers that are published were eligible for this study, and the most important ones are listed here below. And we found quite a variable incidence of low-grade interventricular hemorrhage between 0 and 23.5%, and also a variable incidence of white matter injury between 0.5 and 10.8%. And to our surprise, other injuries, including cerebellar injury, were only sparsely reported. And so here we see Vivian again proudly presenting her PhD thesis, and this is in the center of Zwolle, which is quite a nice little town. As you can see, it was quite windy and cold that day. So the aims of the BIMP study were to assess the brains of moderate and late preterm infants. We wanted to look at maturation, at brain injury, and we wanted to perform brain measurements. We also wanted to assess the relationship between perinatal factors and brain injury, and the relationship between brain volumes and gestational age, and also brain injury. And most importantly, of course, we wanted to look at the relationship between brain injury and outcome. We also compared two cohorts, one in Zwolle in the Netherlands and one in Calgary in Canada. And the BIMP study in Calgary is led by my very good and dear colleague, Lara Leijser. And so this is a prospective study, and we included infants born between 32 and 36 weeks gestational age if there were no exclusion criteria. And the inclusion took place between 2017 and 2020 in the Netherlands and between 2020 and 2023 in Calgary. We collected perinatal data, we performed serial ultrasound examinations from birth until term equivalent age, and a contemporaneous MRI examination. We introduced a classification system, and this was based on the classification system published by Guido Coro in 2013, but we expected milder lesions in this population, and we wanted to focus on these milder lesions, so we adapted this classification system. And of course, we wanted to look at the outcome, and so far we have been looking at short-term outcome at 2 years corrected age. And there are a few sub-studies of this study that I would like to talk about, and those are the ones that are listed here in black. These are the neuroimaging findings, the brain measurements that we did, and these are 2D ultrasound measurements of brain structures and brain volumes on MRI. And the medical technical student applied advanced MR techniques on the MR scans that were performed. And she's still looking at microstructural changes, and she did a great job on artifact corrections. This is way too complicated for me, and so I hope that she will report on this in the nearby future. Furthermore, I will talk a bit about the results of our parental questionnaires that we did at 2 years corrected age. Neurodevelopmental tests are still ongoing in Calgary, and they see the children at the clinic, and I hereby invite the Calgary team to talk about this in a year or so from now, and no pressure at all. And then we did a survey on neurological surveillance in both countries. So during admission, we performed an early ultrasound examination on postnatal day 3, and we repeated this shortly before discharge. Also around term equivalent age on the same day as the unsedated MRI scan. And now I'm going to present some horrible tables to you. I just would like to focus on a few things. First of all, we saw at least one lesion on at least one ultrasound scan and or the MRI scan in the majority of our infants, in more than 75%. Fortunately, these were mild in about 72% of the included infants, and we found moderate to severe lesions in only 6%, which is less than 4%, in only 6, which is less than 4% of our included infants. And if we now look at the two last columns, which represent the term equivalent age ultrasound scan versus the MRI scan, this is what we found. We found a lot more punctate white matter lesions on the MRI scans, and this is what we expected, of course, because punctate white matter lesions are very well depicted, especially on T1 weighted MRI scans, while not so well on ultrasound scans. We also found quite some low-grade interventricular hemorrhages, twice as many on the MRI scans than on the ultrasound scans, and this is thanks to the fact that we included susceptibility-weighted scans to our scan protocol, thus enabling us to see even the smallest hemorrhages. And this was also true for punctate cerebellar hemorrhages that we saw much more often on MRI scans than on the ultrasound scans. And it's well known that punctate cerebellar hemorrhages are not well detected with ultrasonography, while very well detected with especially susceptibility-weighted MR scans. We also found mild ventricular ex vacuo ventricular dilatation quite often, as you can see, and quite often delayed maturation, which was only assessed on the MRI scans. Furthermore, I want to ask your attention for the fact that miscellaneous lesions were more often seen with cranial ultrasound. And these miscellaneous lesions, they include lenticulostriate vasculopathy and germinal lytic cysts and plexus cysts. And we all know that lenticular striate vasculopathy is only detected with ultrasound, while not with MRI. And germinal cysts are much better detected with ultrasound. So we need to realize that ultrasound and MRI are complementary tools and they can never replace each other. These are some examples of lesions. First of all, mild lesions. This is a low-grade intraventricular hemorrhage. We see here a parasagittal ultrasound scan in the preterm period. Here we recognize the lateral ventricle, the choroid plexus, the cingulate sulcus over here, one of the cerebellar hemispheres, here the temporal lobe, here the deep gray matter, and here a small echogenic lesion that of course shouldn't be there, that represents a germinal matrix hemorrhage, confirmed on the susceptibility weighted MRI scan over here. Then this was classified as mild non-cystic white matter changes. This is a coronal ultrasound scan at the level of the trigone of the lateral ventricles, with here the choroid plexus and here the parietal white matter, which is a bit inhomogeneous and too echogenic. And so we classified this as mild non-cystic white matter changes. And the contemporaneous MRI scan shows us inhomogeneously increased signal intensity in the white matter, even in the subcortical white matter. And so we confirmed this mild white matter changes. And here are some examples of moderate to severe lesions. First of all, these punctate white matter lesions, and more than 6 punctate white matter lesions were classified as being moderate to severe, and they are of course well recognized on T1 weighted images. This is a transverse T1 weighted image at high ventricular level, and we see here these sort of clusters of white matter lesions. And this is the parasagittal ultrasound scan beyond the level of the lateral ventricle, where we see here inhomogeneous echogenicity, and maybe with some fantasy we may see here a punctate white matter lesion, but as I said, punctate white matter lesions are not reliably detected with ultrasound. And then here an ultrasound scan performed in a preterm baby included in the BIMP study. And this was the term equivalent age ultrasound scan. And unfortunately, in this baby, we couldn't do an early ultrasound scan due to practical reasons. And what we see here, this is a coronal scan. We see here the dilatation of the right lateral ventricle, the frontal horn. We also see here an echogenic lesion, probably representing an old germinal matrix hemorrhage, and we see here multiple cystic lesions in the frontal white matter. While then on the parasagittal scan, we see all these multiple smaller and larger cystic lesions, and we diagnosed her to have an old germinal matrix hemorrhage, complicated by a periventricular hemorrhagic infarction, which is not very likely when there is a small intraventricular or germinal matrix hemorrhage, but it does happen, as in this patient. And then this is her term equivalent age MRI scan on the same day as the ultrasound scan, confirming the small hemorrhage with extension into the caudate nucleus. We see here the dilatation of the right lateral ventricle. We see here cystic lesions in the frontal area. And very strikingly, we also see that the deep gray matter on the affected side is smaller than on the non-affected side. Also, we see there is no myelination over here, while on the non-affected side, we see beginning myelination of the posterior limb of the internal capsule, which appears later, myelin appears later on T2 weighted images. So this is normal for a T2 weighted image. And we also see multiple cystic lesions, not only in the frontal area, but also in the parietal region. And this baby was quite lucky that she was included in the BIMP study, because she did not have any symptoms during the neonatal period, so she wouldn't have had neuroimaging. And now we were able to offer her a very early intervention program called CIMT, Constraint Induced Movement Therapy, and she's doing really well. She's now 5 years of age, and she has developed just a very mild asymmetry. So the results of our imaging study are published in the European Journal of Radiology, and we concluded that mild brain lesions occur frequently in moderate and late preterm infants, and these include mild white matter changes, low-grade intraventricular hemorrhages, and low-grade cerebellar hemorrhages. Fortunately, moderate and severe lesions are seen much less frequently, and many of these lesions are so-called incidental findings, because we know that they're also seen in apparently healthy full-term babies. And that has been reported by quite some groups, and these are both ultrasound and or MRI studies, and they see the same lesions, but in a lower frequency than what we saw, and they also saw subdural hemorrhages, which we didn't find in our population. So far, we don't know the relationship with outcome yet of these mild lesions. Then brain measurements. First of all, 2D ultrasound measurements. For this sub-study, we not only included our BIMP children, 44 moderate preterm children and 55 late preterm children. We also included 52 full-term born children that were born in Leiden University Medical Center. And this study in Leiden was supervised by Silke Steggerda, my good colleague. And what they did is they performed antenatal head ultrasound scans in healthy fetuses, and they repeated the ultrasound scan after birth. So we were able to compare these three populations. We performed quite a lot of supratentorial measurements, as you can see over here. One infratentorial measurement through the mastoid fontanelle, which is the transcerebellar diameter over here. And again, some quite horrible tables, but I will just show you the significant differences. So we found a significant difference in biparietal diameter between the moderate and late preterm infants. We also found significant differences in basal ganglia width and biparietal diameter between moderate preterm infants and full-term infants, and also between late preterm infants and full-term infants. What we also found was that the corpus callosum fastigium length, which is this distance, was longer in moderate preterm infants than in the full-term infants. And we think that this may be related to the head shape. The more premature the infants are, mostly the more elongated the heads are, and this may have influenced this distance, but we are not sure about this. Furthermore, more surprisingly, we found a larger transcerebellar diameter in the late preterm infants than in the full-term infants, and this trend was also seen for the moderate preterm infants. And we don't have a good explanation for this, although I do have a hypothesis, but I'm not going to talk about that today. And these measurements were done by Femke Sok, a very Dutch name, Femke, and she was a medical student at that time, and we concluded that brain growth in moderate and late preterm infants differs from full-term infants, and whether these differences have clinical implications remains to be investigated. Then the brain measurements, the volume measurements, and these were done by a technical student. She's now a medical technician, and she used the Mantis segmentation toolbox. But she adapted this toolbox for this population because, again, the lesions that we saw were less severe, and especially the CSF spaces were much smaller in our moderate and late preterm infants than in the very preterm infants for which this Mantis toolbox was introduced. And so she compared full volumes of 8 brain structures, 6 of them listed over here, between the moderate and the late preterm infants, and between infants without and with mild brain lesions. And so fortunately, I don't need to show you any table now, because we didn't find any difference in relative brain volumes, which is total brain volume versus structure, between the moderate and the late preterm infants, and also no difference in volumes between the preterm infants with or without mild brain lesions. And here you can see the medical technical student. She's now a medical technician, Anouk Verschuur. And you can see that she's not only likes to look at MRI scans, but she also likes to look at the scenery, the beautiful scenery of the Rocky Mountains, because she spent quite a while in Calgary with Lara Leijzer's group, and she was looking at both the Dutch and the Canadian MRI scans, and she's still doing so. And we concluded that neither having mild brain lesions nor being born moderately prematurely affected brain volumes at term equivalent age in moderate and late preterm infants. And we do realize that some other groups have found different results, but their methods were also different from ours. And then just a few words on outcome at 2 years corrected age. And I'm not going to talk long about this because first of all, these are preliminary results. Secondly, these are from questionnaires. While in Calgary, they see the children at the clinic and they perform standard neurodevelopmental tests and neurological examinations. The aims of this part of the study was to compare outcome between moderate and late preterm infants and to look at the relationship between brain lesions and short-term outcome. So we sent questionnaires to the parents of the included infants, and these were the ages and stages questionnaire to look at development, the child behavior checklist to look at behavior, and the modified checklist for autism in toddlers. And our data or our results are in agreement with many other people that did the same thing in moderate and late preterm infants. We found suboptimal communication in 11% of our included infants and externalizing problems in 8%. We found a normal MCHAT in all children, and some of these groups did see abnormal results of the MCHAT, and no difference between the moderate and late preterm infants, nor between infants with mild brain lesions and without brain lesions. And there was no relationship between mild brain lesions and outcome. But so far, these are preliminary results, and I think we need to await the results from Calgary before we can draw definite conclusions. Then our service on neurological surveillance. There are some recommendations of the American Academy of Pediatrics and the Canadian Pediatric Society that are published to perform cranial ultrasound in moderate and late preterm infants with risk factors. And these risk factors include having a low head circumference, needing resuscitation or needing postnatal intensive care or postnatal surgery, or having other serious complications after birth. Then there are some Spanish guidelines available to perform follow-up in moderate and late preterm infants with risk factors, but there is no international consensus whatsoever despite the increased risk for developmental problems in moderate and late preterm infants. So our aim was to gain insight into local clinical practices on neurological surveillance in moderate and late preterm infants in the Netherlands and Canada. And we focused on medical care, on neurological examination, on neuroimaging, and follow-up. We wrote to 176 Dutch and Canadian level 2 and 3 hospitals, and the response was unfortunately very low. Only 46 Dutch and 34 Canadian centers responded. And so what we found was that some sort of neurological examination, not a standard examination though, was performed in 40% of these centers. Routine ultrasound examinations were done in 23% of the centers, and if indicated in almost 80% of the centers. Routine MRI, as expected, was never done, while if indicated in 90% of the centers. Follow-up depended on the gestational age of the infants. And in infants born after gestational age of less than 35 weeks, follow-up was done in 52% of the centers. And these follow-up visits included physical measurements, physical examinations, of course, neurological examination, again, not standardized, but some sort of neurological examination, answering questions of the parents, of course, and I wonder why this is not 100%, giving advice on nutrition, looking at development and some other items. There was a large variation in duration of follow-up between 1 and 54 months. And this survey was done by Martine Kruse, who is a pediatrician in the Netherlands. And we concluded that we saw a wide variety in neurological surveillance in moderate and late preterm infants among Dutch and Canadian neonatal centers, not only between the countries, but also within centers in the same country. Given the risk for short-term morbidity and long-term neurodevelopmental disabilities, future studies are required to investigate best practices for in-hospital care and follow-up of moderate and late preterm infants. So based on what I just told you during the last, I think, 45 minutes or so, and the results of the BIMP study so far, I have the following conclusions and a recommendation. Moderate and late preterm infants comprise the vast majority of all infants born prematurely. They are also at risk for suboptimal neurodevelopment, for impairments, for behavior and psychiatric disorders, for problems at school age, and even in professional life. And whether these problems are a result of altered brain development or injury is still unknown. As the prevalence of moderate and late preterm birth is so high, even the smallest differences in abilities, impairments, and the need for special education have large socio-economic consequences. And we found quite a high, actually a very high incidence of mainly mild brain lesions in moderate and late preterm infants. And we do need long-term follow-up to assess the relationship between, on one hand, perinatal factors, brain development, and mild brain lesions, and outcome on the other hand. And I think very important to indicate possible vulnerable subgroups that may benefit from neuroimaging and or follow-up. And I think this is even the most important conclusion, because it's undoable to perform standardized follow-up and standard routine neuroimaging in all these babies, but some babies may benefit from this. Furthermore, we hope to come with an international guideline for admission, medical care, neurological surveillance and follow-up. And Lara Leijser, Martine Kruse and myself will work on this after the Canadian BIMP data have been analyzed. And until then, we think that routine neuroimaging is not yet recommended, but we may come up with another recommendation after these Canadian data. And last but not least, I would like to introduce you to my own moderate preterm children. And as you can see, these are monochorionic twins. They were born 38 years ago, quite cute, as you can see. And I was very happy that at that time I was still oblivious to the risks of monochorionicity, but they did well, although there was some color difference between the two of them, as you can see. And now this is one about 1 year ago, and in total they have 2 nice husbands and 5 beautiful children that happen to be my grandchildren. This is my eldest grandchild, my youngest one. And they also do quite well or very well in professional life. So we are very happy with them and proud of them. And I want to thank both BIMP teams. First of all, the Dutch BIMP team. This is about 1/3 of the Dutch BIMP team. This was in my home office from where I'm now also talking. And we were at that time celebrating Vivian's PhD thesis with a symposium, and we needed to organize that online because of the corona pandemic. And this was our home commando center. We had quite some fun, and if you look carefully, you see that Anouk Verschuur is present in both teams. She's the medical technician, and these are our golden research nurses. Without them, we would never have been able to do this BIMP study. And this is part of the Canadian team. And well, I want to thank both of these teams. And of course, I want to thank you for your attention.
That was an absolutely fantastic talk. Thank you so much. And I'm wondering, as I started off at the top of the session talking about your retirement, it doesn't seem like there's a lot of retirement going on.
Is that the first question?
It was an observation, and
Okay.
I aspire to be just like you when I retire and not really leave medicine because I think it's fantastic. Let me just start with the Q&A questions. So the first Q&A is someone who said that they have a preterm 26-week who has developed gram-negative meningitis at 2 weeks of age. And they're wondering if you could comment at all about the prognosis. It seems like the 26-week is a little outside of the window of the ages that we've been talking about, but do you want to throw something out?
That was a gram-negative meningitis?
It says gram-negative meningitis, yeah.
Okay, well, I think it depends a lot on what they are seeing on their ultrasound scans. I mean, I don't know how the infant started, whether the ultrasound scan was normal after admission, and when she or he developed the sepsis, and whether the ultrasound has remained normal or is abnormal by now. I think it depends on a lot of things, but one of them is the neuroimaging findings, of course, the neurological examination, whether there are seizures. And so this is a very high risk infant, of course, that needs a lot of intensive care, and also I think continuous AEG monitoring and long-term antibiotics. But indeed, it's a bit beyond the scope of this talk.
This talk, exactly. So our next question, it says, in the BIMP study results slides, you comment about the incidence of findings and comment that MRI or cranial ultrasound might be better for certain lesions. And this person is looking for recommendations, kind of trying to figure out in which circumstances do which imaging modalities show you the particular imaging findings.
Yeah, okay, so I think every high-risk neonate is entitled to have cranial ultrasound examinations. And so these are preterm infants, well, at least the very preterm population, but also full-term infants with complications, or late preterm infants with complications. And I have a very basic rule that every child that is admitted to a neonatal intensive care needs at least one ultrasound scan. And then it depends, of course, on the gestational age of the baby, and on the imaging findings, and on how the baby is doing otherwise, how many ultrasound examination you do. And maybe you know, well, at least you know that in the Netherlands we do quite many ultrasound examinations. It gives us a lot of information on brain development, on brain lesions, and also on the evolution of lesions. I don't want to say that everyone should do that many ultrasound examinations, but if you do high quality ultrasound scans, then you're not going to have a big surprise when you do a routine MRI scan at a term equivalent age. You will see some punctate white matter lesions, some small cerebellar lesions. You might see some delayed maturation that you didn't pick up with ultrasound, but no large lesions that remain undetected with ultrasound if you perform enough ultrasound scans. And then there are some lesions that you only see with ultrasonography, which include consequences for outcome, but it may point you to another underlying disease. So I think, therefore, it's also very useful to perform ultrasound examinations, and germinolatic cysts are better detected with ultrasound. I hope that is the answer to this question.
I think it's a brilliant answer. I have one kind of follow-on question, if it's okay to ask, specifically for the lenticulostriate vasculopathy. When you find that in your unit, we routinely do urine CMV testing and not a lot more. I'm wondering what is the practice, the common practice in Europe or in other places?
Yeah, well, it depends a little on what the lenticulostriate vasculopathy, this is the only word that I can pronounce better than a Native American person that I've encountered. If you see just a mild sort of echogenicity of these lenticulostriate vessels, I think you don't need to do any CMV testing, because with the modern ultrasound equipments that we use nowadays with the high frequency transducers, we see a lot of these tiny vessels. But if the echogenicity is really bright, and when these vessels are quite thick, I think yes, you should test for CMV. So it
Right.
depends a little on what the LSV looks like.
Gotcha. Okay, so moving on to some other questions here. One says, was there any control for painful or stressful procedures that babies might have experienced while in the hospital? I think this is referring to the BIMP study as well.
That's a very good question. No, we didn't control for that, but in Calgary they're working on that, and I think I'm really looking forward to their data, because they are looking for that. They're also looking at the influence of pain on brain volumes, on a lot of things. So yeah, I really hope we can report on this in the nearby future.
It's exciting and also scary, I think.
Yeah, it is.
To learn what we're going to learn, I think. We have a comment from someone in Argentina who says that they don't routinely do follow-up of babies in this, age range in the hospital. Maybe we should. After seeing all of this, this person is wondering at what age, until what age would you recommend doing the follow-up? And it sounds to me like from your sort of last slide set, like that's the next thing that's going to be worked on, is to come up with perhaps a guideline or recommended screening.
Yeah, I think so far it's a bit messy, the follow-up and also the neuroimaging and everything in these patients. And I think we should keep it like that. Well, that sounds strange, but I think we should keep it like that until we have collected all these data, and especially the perinatal data from the two centers in combination with all the neuroimaging data, because I hope that we will then, and I think we will come with a subgroup that definitely needs neuroimaging, and even more that needs a follow-up. And for now, I think you should rely on your sort of clinical knowledge. If you have a very healthy moderate or late preterm infant, maybe you should see it in the clinic to answer the parental questions and to see whether it's whether it's doing well. But if it's if it is an uncomplicated course, but when you're dealing with a baby who had, for instance, hypoglycemia or had neurological symptoms or wasn't growing well, then I think definitely they need more support.
Right. I think this is again my question, but I think you had said, almost anybody that needs neonatal intensive care in your book deserves imaging. Did I hear that correctly? Because I really love that.
Yeah, I think it's a good rule of thumb, because as soon as a baby is admitted to it, well, not if they're sort of observed for 1 hour because of some arrhythmia or whatever, but if they are really admitted to an intensive care and stay there for more than 24 hours, I think they are entitled to get at least one ultrasound scan.
Yeah.
So, and we have always followed that sort of rule of thumb. And I think it helps us to see the babies that need more attention and also that need follow-up or more imaging.
So I'm not sure how much longer we're allowed to go. It is 1 o'clock, but maybe I'll just ask you or it's 1 o'clock where I am anyway. Okay. I'll maybe just ask you one more question. There's a ton of comments. Thank you for a phenomenal presentation, great presentation. And people are wondering if you would share the slide. So I'm not sure what is the plan in that regard.
I don't know either, but I can check with the NBS, and I'm willing to sort of make PDFs, and so people can ask for the PDF. I know that many people make screenshots, so it doesn't make any difference anyhow.
And also, I think all of these talks are always, the recorded sessions are always available on the webinars section of the Newborn Brain Society website. So I would encourage people to go check out the talks there. But I think that seems like a good place to wrap up, unless you had any other closing comments.
No, I don't think I have any closing comments. I really hope that that very soon we can show you the results of both the cohorts, and then we come up with recommendations. And I think we will come up with subgroups who do need more attention.
Yeah, I think you've made an incredibly compelling case for a group that a lot of us don't think about, right? We think about our term seizing and HIE babies and our very preterm population. And I'm excited to think about this new group. So thank you so much for a wonderful talk. I really, really appreciate it.
You're welcome. Okay, bye-bye. Enjoy your day. Bye.
You too. Bye, everyone.
Recording.